lights for the ambience, and I am going to be streaming me talking about my nursing stuff because I really need to talk out loud to keep myself stimulated and going, and because I'm struggling right now. So I will be doing that. I did not grab my sheets because I was like, man, I really want one of my honey. What's it called? Like, not Welch. You like suck on it, it's caramel. I always say honey, but it's caramel. Caramel. I say both. I don't know what the most popular way to say it is, but I wonder how the dictionary pronounces it. It's probably gonna be like caramel. It's caramel's fancy way to say it. Why is it fancy? Just feels fancy. That's all I have to say about that. Okay. Cool. These. Werther, not Welter. I was keep thinking Welter like that. Snack brand. Ah! Okay. Okay. Are we looking at this? Yeah. That way. Okay. Oh my gosh, my phone would have fallen down my balcony. That would have been horrible. Okay. My phone has fallen so many times. It is so damaged and I am so poor. Okay. Okay. Woo! There we go. Hey, Carlos. Come here, Carl. To know Carlos is to love Carlos. Am I right, ladies? Okay, come on. Come on, Bubba. Come, Bubs. Bubsy. Ah! Hi, Katie. Oh, gosh. Ugh. All right. Carl, is this are you rejecting me? All right, you can chill around if you want for a while. So, here. So, I'm going to try to get through Gulliver and multiple sclerosis at least once and just talk out loud about it. Because I'm struggling so hard to focus. It's a very difficult time right now. But it's going to be great. It's going to be fine. So, I'm going to get it figured out. I am. So anyways, okay. I'm just going to wait through these. It'll be great. It'll be easy. I can do that. Starting with tomorrow. So Gulliver syndrome, also known as GB, so I'm going to refer to it as that. It's a rare, acute inflammatory disease. A rare, acute autoimmune disorder affecting and causing inflammation in the PNS, the peripheral nervous system, right? So, characteristics. Progressive ascending, flaccid paralysis, paresthesias, numbness, and occasionally respiratory involvement leading to vent assistance required. Hi viewer, glad you're here. Talking about Gulliver syndrome. So, BG is a medical emergency. The cause is unknown. We do have a couple ideas of what it can be related to. But genuinely it's so rare and unusual that we don't really know. Anyways, it is an acute inflammatory demyelinating disorder, PNS. Carlos! Come here, Carl. Come here. your collar on. Okay. So you can recover from Guillain-Barré syndrome, or however you say it, Guillain-Barré, whatever, within 2 years, typically, if not shorter, because it is acute. It is not chronic. It's not lifelong. From there, it has 3 stages: progressive plateau / stabilizing stages, whatever you want to call it, and recovery. So, this is where I was kind of talking about, like, you kind of have an idea what might influence it, if not cause it exactly. So we have Campylobacter jejuni, which really I just call Campbacter because it's a dumb infection name. You'll notice that there are many viral infections and other ones that are probably related to this. Don't have exact details, but that one's a specific one that, hey, this is a pretty common cause or influencer in whatever causes GD. So that surgery, viral immunizations. So like if you get the flu shot, like 1 in a bajillion people will get GD. So Campylobacter jejuni, acute infection, surgery, viral immunizations, and other viral illnesses, or those precipitating events / risk factors. Let's talk more about the pathophysiology of GB. So we know it's a rare, acute, inflammatory, demyelinating autoimmune disorder of the PNS, the peripheral nervous system. So what does that look like exactly on a microscopic level? Well, essentially, GB is a pathological process thought to be a result of humoral and cell-mediated immunologic reaction. So we think basically that it's a process that comes to be because of a humoral and immunological cell reaction. A result of humoral and cell-mediated immunological reaction. With that in mind, it's an autoimmune disorder affecting the peripheral nervous system, causing this sudden weakness and ascending, paralysis in the body. It does this by destroying myelin sheaths in the peripheral nervous. So if you're destroying the myelin sheaths in your peripheral nervous system, what's going to happen? Well, myelin sheaths being destroyed in your peripheral nerves, so nerve conduction is going to get worse. So being able to control those muscle stuff is going to get worse. Hence the sudden weakness and loss of reflex response, right? So what's the worst case look like? Complete and total paralysis. Terrifying. Other signs and symptoms occur when nerve conduction to various muscles is interrupted. Sick. So essentially, we have GB, this acute, demyelinating, inflammatory, autoimmune disorder of the PNS. We believe it involves humoral and cell-mediated immunological reaction, leading to the demyelation of the peripheral nerves, leading to poor conduction of the nerves, leading to sudden loss of muscle reflex, this flaccidity, this paralysis, this weakness. And it goes ascending, like I said. So feet up. Precipitating events / risk factors: Campylobacter jejuni, viral immunizations, viral illnesses, surgery, and acute infection. Recovery could take up to 2 years. In the worst case, you might need an event and you have complete and total paralysis. So how do we diagnose this pretty scary thing? Because again, it's very rare and we don't know a lot about it. Well, it's going to be largely based off manifestations. Do you have those precipitating factors? Let's rule out other potential causes of these manifestations. What's their history of recent viral infections and or immunizations? the other big thing, we're gonna tap into their lumbar puncture. We're gonna do a lumbar puncture, tap in their spinal cord. We're gonna squeeze what we get out. We're gonna look at it on a microscope. We're gonna see elevated protein levels. We're gonna do electromyography, EMG studies to see nerve conduction, which will probably be decreased because we're having demyelination of those nerves, right? So that's probably what's going on there, right? So that is pretty much it. So it's really just the old glory. Hi. I'm glad you're in this stream. Let me know if you have any questions. So basically, we diagnosed Guillain-Barré, GB. Pretty simple. We're going to say, okay, what is our client showing as symptoms? LeMayo, I have no clue what it's about, but I'm listening. Okay. Well, would you like me to re-explain it? Are you interested, or do you just want to hear me talk? If you have any questions, let me know. Are you in medicine? Are you doing anything with healthcare? I'm in nursing school. That's why I'm studying this stuff. No, go on. I ain't trying to break the mojo. Listen, I'm good with any mojo. I'm just talking. You're in law enforcement. Or was until like why is that? Law enforcement. Does that mean you were like a police officer? Or like the legal system? Got a new job at a family company. Well, yay! Congrats to you! I hope you're enjoying it. Oh, sheriff deputy working in the jail. Well, that's gotta be interesting. Did you see any weird medical things that happen in the jail? Like, did you ever see anyone swallow a razor or something or whatever? Since, I don't know, I'm just curious. Appreciate it, big dog. Anytime, fellow big dog. Saw weird medical things every day. Well, feel free to share. Anyways, I'm gonna keep talking, but I'm glad you're here. Thanks for coming. So, Guillain-Barré syndrome. How are we gonna diagnose it? Let me tell you. One more time from the top. There's 4 things we're gonna do, basically. What are the manifestations? And what's the patient's history? So for the manifestations, we're gonna look for those key things, especially the ascending paralysis / weakness of the muscles. Because first, they're not gonna be able to move their toes. Like, they're not gonna be able to move their toes before they can't move their fingers, you are. Yes, so ascending, right? Feet to the head. Whoop. That's the key one. And then we're gonna look at their history and we're gonna be like, all right, do they have any of these precipitating factors or events, risk factors, whatever you wanna call them, it doesn't really matter. Have they recently been exposed to a viral illness? Did they recently get a viral immunization? Were they on like Campbell, whatever, Junie, that infection, acute infection, surgery, yeah, all that good stuff. From there, we're gonna rule out other potential illnesses that might be causing these manifestations, such as, like flu-like disorders or the flu itself, Lyme disease, heavy metal poisoning, all that sort of mumbo-jumbo stuff. And then we're gonna get that lumbar puncture, so we're gonna get this big old needle, and we're gonna whoop, step into the lumbar, and that spine, we're gonna get out all that lumbar CSF, cerebral spinal fluid goodness. We're gonna squirt it out, put it on a little tray, look at it in the microscope. You can't see. Microscope, that's what I was doing. This is a binocular, it's not a microscope. So we're gonna look at our microscope and and we're gonna see, what's going on there. And with Guillain-Barré syndrome, we're gonna have an increase in protein levels. Oh, I see something. Oh, Flying Bianca! Thank you for following. Oh glory. Nasty and badass at the same time. Dude, lumbar punctures are crazy. Crazy. I got to see this epidural at my OB clinical, and I was like, bro, the needle is literally like this big. It's wild. It's wild. But it is what it is. I'm studying some pretty cool stuff because I'm talking about neurodegenerative disorders. Yes. And so the last thing we're going to do to diagnose this, oh wait, I saw one of them. one of the IVs that drill into the bone. I can't remember what it was called, but I fell for the guy. An IV that drills into the bone? The Wicked Witch of the West? Wait, I gotta look that up. I've never heard of that. Or maybe I have and I forgot the name. It's been a crazy semester. I want to look that up. An IV that drills into the bone. Was it an IV like they put it into the vein? Or was it like to keep the bones in a certain place? Was that intraosseous infusion? What? Intraosseous infusion. Oh! Yeah, that's not a pretty process. So this is why we've briefly touched on this, but we learn more about that in my next semester. That is legitimately wild and looks so painful. Yikes. Well, hey, thanks for that. I learned something new. Anyways. Last thing we're gonna do oh no, dude, you're fine. Don't even worry about it. Don't even worry about. That's why I like to stream. It's because if you can't tell, I have ADHD, and it helps me to interact with others and feel like I'm not just talking to myself over and over and over again. I just blacked a spider, and I have immediate regret. Hope it's not in my sweatshirt now. Anyways, you're fine. The last thing we used to diagnose is EMGs to the electromyography thing. So what that's going to show is going to show us, electrical impulses of the nerve conduction. We already discussed this is a demyelinating, acute inflammatory autoimmune disorder that affects the peripheral nerves. So it's going to literally destroy those peripheral nerves, which is going to, someone got pulled over. Man. Anyways, it's going to affect that nerve transmission. It's going to get worse. It's going to go down. So what we're going to see in those EMG studies with GD is that the nerve conduction is decreasing because we're having this loss of reflex because of it. So, that's that. We're going to move on to nutrition-related nursing care. So, we talked about how GB, in its worst-case scenario, can literally cause complete paralysis. So you won't even be able to literally... You can't close your eyes on your own. You can't breathe on your own if that occurs. You literally have to have a vent. Now, it can take up to 2 years to recover. Someone's messaging me. Someone sent me a message. Okay, someone sent me a message I actually have to respond to. I hope my stream doesn't get lost. I'm sorry. I hope it please don't get lost. I'm sorry I had to answer a message for school. Anyways. Nutrition really cares. So what I was talking about was, you're gonna be, if you get GB, there's a high chance that you're going to be bedbound, even if you don't have complete paralysis. Even if the paralysis stops at your hips, maybe not even bedbound, but chairbound or whatever. You're going to be sitting and or laying down a lot for long periods of time. Oh, hey, 2 new viewers. Hi, welcome to the stream. I am covering Guillain-Barré syndrome right now, and I'm discussing it. If you guys have any questions or you want to tell me anything or ask me a question in general, something about your day, please do. I'm so glad you're here. Back to the stream. So, what happens is this. We need to provide nutritional support for these patients, especially because if, paralysis occurs up to their stomach even, they can't absorb the food and nutrition on their own because we have this ascending paralysis, so it's going from their feet up, right? So that means after a certain point, they will no longer have peristalsis, and peristalsis is, the involuntary, like, we aren't consciously moving this muscle. Our stomach is moving food and our digestion and that stuff along. I have someone wanting to buy something from me now. Hey. Also, studying. Okay, so, I lost the viewers, RIP. Anyways, I had to respond to that. I sell these sheets that I'm studying. I make them, because I'm very, very, very broke. Okay. So, point is, they can't feed themselves properly, especially if infects in their mouth. They can't chew. They can't swallow. It's going to lead to difficulty with that, so dysphagia. And absorption. So that's a whole other conversation of how they'll likely need to get onto an NG tube, PEG tube, or a parenteral nutrition, even because their body literally can't process, digest, to eat food at all. So, what can I do as a nurse? Crap. I want to maintain a positive nitrogen balance. I want to ensure that my patient gets sufficient fluid intake and calorie intake every day. I want to make sure that they have the proper electrolytes and that they're all in balance. And I will help provide that total parenteral nutrition if it is indicated due to swallowing problems and such. And the not PEG tube, gastrotomy, I don't know why I said PEG tube, gastrotomy tube feeding is ineffective. So, maintain positive nitrogen balance, ensure proper fluid and electrolyte and caloric intake, provide total parenteral nutrition if indicated, if the NG tube and or gastrotomy tube just are ineffective at providing those things for our patient. So let's go to medications. This is what we give them during the progressive phase. We have 4 months. So, this is what I can know. You can give IV immunoglobulin. So IVIG is what it's sometimes called. Hello, new viewer. IV immunoglobulin. Basically what that does is, so we have to remember, in GV, it's an autoimmune disorder, so our body is attacking itself during this time period, even though it's not chronic. So while we have it and it's active, our body's attacking itself. So by providing intravenous IV immunoglobulins, we then have these separate immunoglobulins going to the body to help suppress the antibodies our body is making. That way we help suppress that immunologic reaction to help damage control. And prevent further attack to the myelin sheaths. Oh, my sticker is crumpled. Oh no, our table is broken. Okay, so myelin sheath, Golden Bear medication. So first is IVIG, IV immunoglobulins, where we're going to have these immunoglobulins go into the patient to help suppress the antibodies that are attacking and destroying our myelin sheaths, therefore preventing and lessening damage. From there, our patients, they can't move, but man, they can feel. They can still feel perfectly fine. Ergo, they're going to be in a lot of pain. A lot of pain. So they're going to require morphine after a certain point to best control their pain because it will be so severe. Again, it's all pain related to their muscles because it's all jacked up. I mean, like, your muscles are literally on a microscopic scale being destroyed because the myelin sheath is being destroyed due to that peripheral nerve damage, right? So, That's what causes that decreased nerve connection on, that shows up in the EMG, and that you can't do your muscle reflexes and stuff. So pain is a problem. We control that muscle pain with morphine. Next, we have to think our patient is immobile again, right? No matter what the degree is, whether they're chair bound or bed bound, whatever the situation, whatever the severity is, they're going to be immobile for quite some time. Even if it doesn't take 2 years to recover for them. It's probably going to take at least 6 months, I think. So they're going to be very immobile. And something you don't necessarily know if you aren't in medicine is that prolonged immobility leaves you susceptible to issues with coagulation of your blood or clot formation. That's our deal. Because you're not moving and grooving, my guys. It helps a lot just to do basic exercises because of things like that. So we're going to want to get them on anticoagulant therapy to help prevent any potential complications due to their prolonged immobility. Specifically, we want to prevent thromboembolic complications. Does anyone know what a thromboembolic complication is? And anyone want to give me an example? Probably not, it's fine. I'm gonna put my computer on. Okay, so I'm getting chilly. I gotta adjust my blanket and make my heater go high on the heat. Okay, thromboembolic complications that could be occurring: deep vein thrombosis, pulmonary embolism. These are both associated with prolonged immobility, bed rest. So, yeah, we want to prevent those complications and keep them on anticoagulation to prevent that DVT, deep vein thrombosis, and pulmonary embolism. Next, we are laying down or whatever all the time. Again, immobility problems. Ergo, we're going to make sure that we get our kiddos, our patients, on vasopressors. Vasopressors will help control the blood pressure to make sure we're still big chillin' and big healthy. It's prescribed whenever hypotension is a problem because everything is too relaxed. Not every patient gets it. You might be on it for a while and then not later. But vasopressors are given to patients with GB if hypotension is indicated, like a problem. So we have finished the first side of GB. Oh, I got a text back about my business. I love them looking up on Bitcoin, but the things we listen. Perfecto. Yay. Let's move on to the next page. So, any questions so far? Anything anyone has? The next things I'm going to cover are very specific manifestations. Obviously, GB, as I have been stating over and over and over again, is sorry, I got a business thing. Obviously, we know about the ascending weakness, but there's more to it than that. So we want our nursing care summarized, our non-pharm treatment, and our manifestations. Give me 2 minutes really fast to talk to this person so that I can get my stuff. Okay, now I'm just going to email this to them, and I will be all done. Send this to them. Give all my stuff. There we go. There's that. There's copy 3 items. There's that. There. Okay, all my stuff has been typed. Yay. So, manifestations. We're gonna have symmetrical weakness, massing paralysis. So basically, whenever my feet go numb and cruddy, both my feet are. It's not just gonna be my left one. I sent it all to you. Okay. So we're gonna have paresthesias, and if you don't know what paresthesia is, that means numbness and tingling, typically developed in the feet and hands. So we're gonna have paresthesia, symmetrical weakness in ascending order. We're gonna have absent DTRs. We're gonna have no deep tendon reflexes at all. And we're gonna have pain. We're gonna have that muscle pain. So paresthesia, pain, absent DTRs, symmetrical ascending weakness, / paralysis, whatever, cardio. Yeah, that's pretty much it for that. So, let's look at a summary of our nursing care. Our 2 main priorities are going to be acute pain control and keeping skin integrity. So, we want to make sure we keep their pain at a minimum, and that throughout this we don't have any pressure ulcers or anything bad like that happen. So, also a vital thing, we want to maintain the patient's airway. We want to monitor for aspiration, pneumonia, respiratory failure. We want to prevent skin breakdown. We want to provide that adequate nutrition we were talking about earlier, and hydration. We want to provide patient and family education. So, airway, nutrition, preventing complications of pneumonia, respiratory aspiration? Respiratory failure? What is going on with me? Monitoring for aspiration, pneumonia, and respiratory failure. Skin breakdown, we want to prevent that from happening. And all that crazy junk, keep that nutrition good. All that good stuff, provide education to the patient and the family. So, that's that. Non-pharmacological treatment. Basically, everything else we do is just highly supportive. It's really about nutrition, fluids, and then physical therapy and orthopedic therapy. So, besides that, we have plasmapheresis we can offer. You're like, Phoebe, what is that? Oh my gosh, let me tell you. I would so love to. Plasmapheresis. Okay, so its plasma exchange is helpful and particularly beneficial when performed early on in GB. So plasmapheresis is the most beneficial early on. So that's another, motivator to catch this disorder early on. Antibodies are removed and immunosuppressive agents are administered concurrently. So we get out the antibodies that are crapping on our body, and we help suppress, that attack that our body's causing with antibodies with immunosuppressants. Whew! Patients can have 3 to 4 transfusions within an 8 to 10 day period. Sick. Then the occupational therapy. Long-term physical occupational therapy is the most important during the recovery period. It is absolutely crucial to recovery, and it is absolutely crucial to prevent things like contractures from forming. GB patients tend to require prolonged rehabilitation care, typically beginning in the acute phase and focusing on preventing complications and limiting effects of mobility. So we want to be able to keep them as healthy as possible so that whenever GB does pass and goes away, that our patients aren't, any worse off than they had to be. From there. Severe muscle atrophy and loss of muscle tone require patients to relearn many functional skills such as walking, which is very sad in those more severe cases. Compromise in respiratory function may delay physical rehabilitation. So even though you might be, starting to recover or whatever, or maybe you've been doing acute hair PT, you as it progresses, your respiratory muscles get involved, and then if you can't really breathe, basically, you're struggling to, you don't have effective breathing going on, you can't really do physical therapy. At least not well. It's going to be delayed or diminished therapy The patient, it's really important as a nurse to give the patient a lot of encouragement for any success, literally any, even if it's just like moving a little bit of a finger. We should be like telling them, no, that's a big deal, that's great, because it honestly is. It's a huge deal, and it is great they freaking are doing that. I'm proud of them. Lastly, we want to continuously have attention to the patient's pain control. Pain control is so essential because paresthesias and pain can interfere with patients' physical therapy along with everything else. It's just going to tank their freaking quality of life that's already taken because they got GD and it sucks. Now it's like, oh, we have GD, this is great, That's not how that works, sis. That's not how it be working. Alright, almost done. I have my last few things about GB, this last sheet. I went a lot into breaking everything down a moment ago, but this is going to be the summary, so I'm just going to kind of walk through it and repeat it. I will say one thing though, I really have to pee, so I'll be right back. Oh wait, what's going on? Oh, crud buckets. I told this on my phone really fast. Carl, you want to sit with me? Carl? You want to sit with Mom? Carl? Carlos? You want to sit with Mom? You look like you do. Come here. Come here. Come. Oh, come on. This is Carlos, my puppy. There. That way you can be a little warmer and less lonely. One less lonely girl, one less lonely Carlos. Alright. Speed round. Let's talk about Guillain-Barré syndrome stages. The characteristics. So, in the progressive stage, symptoms peak in the first 1 to 4 weeks of onset. Main characteristics is severe rapid weakness, particularly in the lower extremities. Again, that symmetrical paralysis, weakness stuff. We're gonna have this loss of muscle strength. This can lead to quadriplegia and respiratory failure. Look how cute he is. He's so cute. I love him. Oh! My little boy, my little man. Oh. Okay. So we're going to have decreased CTRs, vital capacity. Paresthesias, numbness, pain, especially at night. So with GB, pain's going to get worse at night. You're going to have inability to wrinkle your forehead and change expression if it gets up to here because of facial muscle involvement. So autonomic nervous system involvement manifestations is going to include bradycardia, sweating, and fluctuating blood pressure. So ANS manifestations in the progressive period of GB, bradycardia, slowed heart rate, flushing and fluctuating blood pressure. Okay. Stage 2, stabilizing / plateau stage. This lasts between 2 days and 6 months. You heard me correctly. Sucks. It's characterized by the leveling off of symptoms. It's not just rapidly getting worse and more suddenly. It marks the end of changes in conditions. So once you're at this stage, then you're mostly not going to have like any other weakness added to whatever you're getting. And again, that worse case scenario between total paralysis, quadriplegia, and respiratory failure. It is generally labile autonomic functions stabilized. So like the bradycardia, sweating, fluctuating BD. Stage 3. Last stage, the recovery stage. Yay! Generally, recovery stage takes between several months to 2 years. So, first stage, symptoms peak in the first 4 weeks. Second stage, 2 days to 6 months. Recovery stage, several months to 2 years. Recovery stage is characterized by improvement of signs and symptoms, and generally muscles start to strengthen and function will start to occur, or whatever, in descending order. So we lose our muscle function in ascending, and we regain it in the descending order. So it goes backward. So, progressive stage, sudden ascending symmetrical paralysis. Plateau, levels out, stops getting worse. Recovery, the patient improves, and nerve conduction returns and ascending. Yay. Look at him. I love you, Carlos. Oh boy. Nursing care focus. Remember, our 2 biggest priorities are preventing skin breakdown. You want to promote that skin integrity, and then also helping control pain as much as possible. So, our generalized nursing care focus from there. Preventing potentially fatal complications by following rigorous, predetermined schedule for turning and respiratory care, strict aseptic technique, and providing continuous psychosocial support. We want to monitor our neurofunction, prevent immobility problems with contractures and stuff. Remember, immobility, we're on those anticoagulants for the DVTs, the pulmonary embolism, we're going to be potentially on those vasopressors if the patient has hypotension. You get contractures if you don't move as best you can. It's a whole thing. Also, immobility again, pressure wounds, not good. We want to ensure adequate hydration and nutrition, that positive nitrogen balance, all that stuff, promote respiratory function, anticipate needs of patient and family. For example, developing an alternative method of communication before it becomes necessary is a really great way to decrease anxiety. So we know that we're going to lose function in ascending order, and so we need to figure out fast how can we communicate after this, because there's going to be a long time potentially where we can't communicate how we normally would with people. How do we assess this? In our initial stage, we treat GB as a medical emergency because it is one. Our big priority is maintaining that airway because they could have that total paralysis and require a vent. That's no laughing matter, you guys. That's very, very serious. So we want to maintain that airway, otherwise our client will die. We want to assess oxygen, saturation, so O2, vital signs, and work of breathing. So are they breathing symmetrically? Is it struggling? Is it labor breathing? That's our deal. So, assessment moving forward, since GB is progressive. We should regularly assess patients' strength and their ability to move their extremities. Changes in assessment is something we should immediately report. So like we said, in those first 4 weeks of GB, you have the most worsening changes, and we want to keep track of that very well. So we want to always immediately report that as soon as possible, as soon as we find them. We continuously assess patients' pain, of course, and we provide appropriate pharmacological and non-pharmacological pain management techniques for that to provide comfort as best as we can. The pharmacological thing we're going to give is morphine for that muscle pain. So next is we want to control acute pain. Pain can vary from frequently stocking glove pattern with pain in hands, feet, and legs. Frequently stocking glove pattern of pain with hands, feet, and legs. Interesting. So we want to listen to pain descriptors, determine presence of triggers or pattern for pain, use pain scale to determine extent, use complementary therapies to manage pain, heat cold application, guided imagery, relaxation techniques, massage. Analgesics is indicated. Administer on a regular schedule versus waiting until pain becomes severe. So we're not going to wait for their pain to become severe to give them their pain meds. No, we're going to regularly give them their pain meds to have continuous pain control. Because we're continuously giving that pain control, such things as morphine, which big complication potentially, respiratory failure, because it depresses the respiratory system and the CNS and stuff. Look how sweet Carlos is. Oh my gosh. Do you see the sweetness? Look at this sweet little man. I love him. I love him. He's a yummy boy. Oh, I love him. So we want to monitor for the side effects of analgesics, just morphine. Especially that respiratory depression, So, we're going to regularly assess the lung sound and how well they're breathing. Yeah, that's right. We are going to perform routine pulmonary care measures because we want to monitor for aspiration, pneumonia, and respiratory failure. Again, monitor aspiration. Almost done! Last thing. Promoting skin integrity. During the plateau stage, the patient's risk for problems related to mobility and malnutrition increases the most. Oh, so nice. That was weird, but yeah. So, what are we going to do? I keep thinking I'm getting a text message. What the heck's going on? My watch. I emailed them to you. Did you not get them? There. We want to inspect bony prominences and provide skincare every 2 hours. Like I said in the beginning, big deal is preventing potentially fatal complications by following strict, rigorous, predetermined schedule for turning, respiratory care, strict substitution, and providing continuous psychosocial support. So we're going to inspect their bony prominences. We're going to inspect all parts of their body every 2 hours minimum. We want to reposition the patient and clean, dry, lubricate skin as needed. So, if they're dry, add some lotion. If there's incontinence or something that occurs, wipe it up, clean it up. Don't want that skin breakdown. You want to pad bony prominences. What are those bony prominences? Oh my gosh, my sacral area, my heels, and my elbows. Hi, new viewer. How are you? I'm going over Golden Bear Syndrome. Welcome. Enjoy. Feel free to say whatever you want to chat, ask questions, tell me about your day, whatever. And then last thing, oh my gosh, monitor for incontinence. We want to monitor for incontinence and provide thorough skincare following each episode of incontinence, because again, if they're just exposed to urine and or fecal matter, that's going to cause skin irritation and skin breakdown. That's just how that works. It's not good. They can't clean themselves. They literally can't move. They can't even breathe most of the time, or eat or talk or anything. They are completely reliant on you. And they also, I'm almost starting to have complete cognitive awareness the whole time, so very, very important to treat them as best as possible, have that continuous care, and come up with interventions as best as possible for communication stuff. Alrighty, so that is GB Golden Bear Syndrome. We finished it. Oh my gosh, so proud of us. Alright. There we go. I'm sorry, Carlos. I'm sorry. Oh, kisses. I'm sorry, guys. Okay, I need to turn this off now. So Carlos has this bark color thing. Don't worry, it doesn't shock him. I would never get a bark or a shock color for my little man. No. But he does bark a lot randomly, and so it just will trigger a loud noise and a little vibration. It's not painful at all. It's just, it's enough to get and be like, oh, what's going on? Maybe spook him a little. But anyways, sometimes I trigger it by accident. Honestly, I actually think I'm going to take a bit of a break from streaming. I'm really hungry. I need to make food. So I'm going to do that. But thank you to anyone and everyone for joining. And this has been great. Good talking to you, Old Glory. Oh, wait, who's this? JJ, yes. That's the cutest dog I've ever seen. Hi, JJ, yes. Thank you. His name is Carlos. Normally on my streams, I have the Carlos cam, is what I like to call it. Oh, sorry, Bubba. So that you can see what I'm doing and what he's doing, He's the best. He's my little man. He's my emotional support dog. My boy. But it's kind of funny because every time I cry, I'm like, ah. He always runs away. But he comes back when I calm down. He's like, I'm here for the after sport. But yeah, just a little joke. Anyways, you caught me at the end of my stream here. But I stream a lot, so feel free to follow me. I stream very, very often, especially study and art streams if you're into that kind of thing, and random video games here and there. I hope you're having a good night. And you can see more of Carlos and me. He said, okay. Well, yay. Hope you give me a follow then. Movie streams. Let me grab my thing. Ugh. Good night. You have a good one, okay? Thanks for joining. Bye.